Good morning, everyone. So even despite daylight savings time, I think I have 7 o'clock on both my devices. So we'll get rolling with grand rounds here. Um, Following grand rounds, we have unknown conference, and so we'll all be able to stay on the same WebEx and not switch from one to the other. So with that being said, I was going to turn things over to Dr. Farhat to introduce Dr. Shannon for grand rounds this morning. Waleed.
Hi, good morning, everyone. It's my pleasure to introduce Dr. Cannon to present on disparities in pediatric urology. I think it would be worthwhile just to educate myself even on the fact that urology remains one of the professions or medical disciplines that is having the fewest and most underrepresented minorities and women. Shannon is really aware of this problem since her residency and possibly since her medical school at UW. And as a new recruit, she had been very much actively working with a group of urologists called Urologists for Equity. And she's working really hard to evaluate the scope of the problem and also identify solutions. I personally knew that urology has a diversity problem, but I guess pediatric urology is not immune to the same problem either. So with disparities as the metric for equity, I think Shannon will present on disparity in pediatric urology, and hopefully we'll all work hard to support her and make this less and less of a problem in the urology discipline. Shannon, thank you.
Thank you for that introduction, and let me just go ahead and share my slides. Are you able to see my slides?
No, not yet.
Oh, okay. Okay, hopefully you should be able to see it now.
Yep, we can see that.
Great. Well, again, thank you for the introduction and for the opportunity to present today. For those who don't know me, I'm Shannon Cannon, and I'm one of the new pediatric urologists on faculty, and I'll be speaking about disparities in pediatric urology. The goal of this presentation is to characterize known disparities that affect access to care and delivery of care within pediatric urology, and to begin to think about how these disparities affect our patients and their outcomes. I will touch on possible interventions and research aimed at eliminating the disparities we discussed today. For a little history, pediatric urology is a relatively new field where previously the pediatric urology patient was shared between the adult urologist and the pediatric surgeon. The Society of Pediatric Urology was formed in 1952 by a handful of urologists who had particular clinical and research interests in the pediatric population. And over time, this group grew slowly, and it wasn't until 1994 that there was a section in the Journal of Urology devoted to pediatric research. The Journal of Pediatric Urology was started over 10 years later in 2005. And a subspecialty certification was eventually granted by the American Board of Urology in 2008, which really did change the landscape of this field somewhat. So as a relatively new field, early studies that dealt with disparities in care as it related to race or socioeconomic differences were primarily single institution studies or statewide studies, or unfortunately, very rudimentary comparative studies that focused on race. However, this study that is in the center here is from 2016. So even as recent as then, our efforts have still highlighted, a problem in the very problematic nature of this type of research, which we had discussed in our journal club recently, regarding the notion of race as a proxy for socioeconomic and geographic factors that affect access to care and delivery of care. What we now see is an improvement on earlier research but it remains primarily descriptive in nature, characterizing disparities as best as possible, utilizing data sets which are available, but also undersample minority populations, and often lack granularity in patient demographics such as race and ethnicity, location, education, or income. And they persist to use race as a proxy for other socioeconomic factors. So with this grain of salt, I will touch on disease areas within pediatric urology and highlight some of the more prominent research into disparities in care in cryptorchidism, spina bifida, testicular torsion, and newborn circumcision. I'll also highlight some areas of emerging research and finally discuss some opportunities for intervention. Cryptorchidism is common, occurring in 1% to 3% of boys born in the US every year. The recommended timing for performing orchiopexy has changed over the years, with earlier recommendations for older age to do the surgery around 5 or 6 years of age due to the risk associated with anesthesia. But in 1996, the American Academy of Pediatrics section on urology recommended that it be done by 1 year of age, and that was with the advances of anesthesia. And by 2014, the American Urological Association recommended referral to the urologist by 6 months of age and orchiopexy within the next 12 months. It is clear in practice and in our guidelines that appropriate care is dependent on timely referral and surgery. To identify factors that were associated with timely surgery, a group at Boston Children's used the Pediatric Health and Information System database, studying 28,000 children who had undergone orchiopexy between 1999 and 2000. They defined a primary outcome of surgery before 2 years of age and found that race and insurance status were associated with timing of surgery, with Black patients less likely to have surgery before age 2 than their white or Hispanic peers, and those with public insurance were less likely to have timely surgery than those with private insurance. Researchers at UCLA used the Innovus i3 private insurance claims database to study 4,000 plus children over a 5-year period. And they compared this to a reanalysis of the FIS data to compare privately and publicly insured cohorts, and finding that timely surgery was associated with continuity of care with a primary care provider, seeing a pediatrician rather than a family medicine or internist for well-child visits, and laparoscopic surgery, which suggested a more severe presentation, such as having a non-palpable testis. Publicly insured patients, again, were less likely to receive timely care in this study. Single institution studies have also demonstrated similar findings of decreased rates of timely orchiopexy among Black and Hispanic patients. They also found that publicly insured patients were 2 times more likely to be delayed in surgical treatment, and noted that a majority of white and Asian patients had private insurance, whereas a minority of Black and Hispanic patients were privately insured, suggesting that some of this decrease in rate of timely orchiopexy was related to insurance status. A group at OHSU examined reasons for delayed referral, with referral at 18 months of age considered delayed, although this is significantly more than what our AUA guidelines recommend for referral to a specialist by 6 months of age. They noted that patients who had normal testes at birth, a diagnosis of retractile testes, or a diagnosis by someone other than their primary care provider were associated with a delayed referral. And they also found that those who did not speak English as a first language were delayed, but this was on univariate analysis alone and did not bear out on multivariate analysis. Notably, however, 29% of patients that were included in this study had health or social issues that contributed to a delay in their care. So from the research to date, we can surmise that orchiopexy is more often delayed among the publicly insured, and delays may disproportionately affect Black and Hispanic patients, in part due to higher rates of public insurance in these groups. Timely surgery is dependent on the time to referral to seeing a urologist, and the time from consultation to surgery. So there are many components where delays could occur, and I think there's still some opportunities for research into these areas. So how do delays affect the patient? The potential for testicular growth after orchiopexy decreases after 2 years of age, with previous studies looking at ultrasounds of boys who've undergone orchiopexies and saw that testicular catch-up growth was reduced after the 2-year time frame. So this time frame is very important. Additionally, the cryptorchid testis may have fewer germ cells at baseline. This has been shown on previous testicular biopsy specimens. And then further research showed that delays beyond 15 to 18 months of age for performing orchiopexy have been associated with lack of germ cells seen in testicular biopsies, meaning that there at that point is already the potential for significant decreases in fertility potential for these patients. Additionally, the risk of testicular cancer is higher in these boys where orchiopexy is performed at a later date. So the risk of testicular cancer on meta-analyses have been shown to be 3 to 32% higher, or 32 times higher in boys who've had orchiopexy after age 10. And in a Swedish cohort that looked at the incidence of testicular cancer, they found that there was an age-dependent increase in testicular cancer, as you can see from this table here. Going from 0 to 6 to 16 to 19 years of age, there's a 4-fold increase in the rate of testicular cancer for people who've waited that long to have orchiopexy. We counsel patients on the need for timely orchiopexy in our clinics to optimize fertility and minimize additional cancer risk. So it's disturbing to know that these delays are more likely in some groups of our patients than others. Next, I'll focus on urologic outcomes in spina bifida. The establishment of a national spina bifida registry has allowed us to evaluate patients on a national scale and perform longitudinal studies of their health outcomes. This registry, which was formed in 2008, has grown over time and now consists of 22 clinics and to date has included over 10,000 patients. There's a higher prevalence of neural tube defects in Hispanic populations, and this has been studied in some respects and shown to have some associations with environmental exposures, specifically with folate deficient diets. And there have been previous studies that demonstrated that supplementing diets with folate have actually decreased the prevalence of neural tube defects in this population. However, other studies of looking at sociodemographic factors and their association with continence has also shown that there's a higher risk of urinary or bowel incontinence in this group, and the reasons for this have not been studied yet. So an early look at the National Spina Bifida Patient Registry data identified sociodemographic attributes that were associated with bowel and bladder continence. And I know this graphic is poor fidelity and small. This is the highest resolution I could get, but you'll see here that females were found to have a higher likelihood of bowel continence, and there was decreased likelihood for bowel and urinary continence for Black and Hispanic patients and for patients without private insurance. These other components do show that there's an age-dependent difference in continence, which is somewhat expected, as well as there's a difference in continence based on the level of lesion and the severity of disease, such as having myelomeningocele or not. But really, among these sociodemographic factors, we're really at the characterization stage and not at understanding the whys for these findings. More recent studies of the registry have redemonstrated these factors as associated with decreased urinary and bowel continence, including myelomeningocele, which is considered kind of the most severe form of a neural tube defect, thoracic lesions, which are the most severe lesions in terms of height on the spinal column, and then non-ambulatory status, which is also a proxy for disease severity. Findings also found, they also found that there's no history, if a patient had no history of previous bladder or bowel management or previous bladder surgery, there was a higher rate of incontinence. And then looking at those sociodemographic factors again, the non-private insurance, male gender, Hispanic ethnicity, and Black race were associated with decreased likelihood of urinary and bowel continence. And these studies actually carry over into adulthood, where they, studies have found that these socioeconomic factors continue to keep the patients at risk because a large number of these patients do not have private insurance, do not have full or part-time employment, and many of them have a pretty low education level with a high school education or less. So we know that there are increased risks of rates of incontinence among pediatric spina bifida patients who do not have private insurance or who are Black or Hispanic. And many patients remain on public insurance into adulthood. There are studies that have already shown that continence status has significant impact on quality of life, and that has been shown in this patient population as well. And so we must do more to understand why these disparities exist so that we can work to achieve parity and hopefully improve these patients' quality of life. When we consider testicular torsion, rates of orchiectomy are related to timely presentation and surgery. So, a lot of the data and research is around this. A group in Turkey examined their own cohort of torsion patients, separating them into groups based on education, use of public insurance, and government assistance. And they found that there was a higher rate of orchiectomy among patients whose parents were who had education levels that were less than high school level, or who were on public insurance or receiving government assistance. Researchers who looked at HCUP kid data studied 2,000 plus boys who had torsion in the 2000, 2003, and 2006 data sets, and identified factors that were predictive of orchiectomy. These included age less than 10 years, public insurance, Black race, or location in the Midwest or South region. And right around the same time, another group did a very similar study using FIS data, which is again the Pediatric Hospital Information System. So this study looked at 2,800 boys with torsion over a 6-year time period and found near identical factors predictive of orchiectomy in a different data set: age less than 10 years old, Black race, and then public insurance or self-paying insurance. Several studies have tried to identify whether inter-hospital transfers have increased the rate of orchiectomy, but these studies have presented conflicting data, and most of them have been limited to single center or statewide studies. Additionally, not all of these studies have considered in the same manner baseline differences and potential for testicular salvage between patients who present early within the first 24 hours of their symptoms and those who are delayed, who have presented after 24 hours have passed. It is clear, however, that since the introduction of the Pediatric Urology subspecialty certification, transfer rates have been increasing overall. So in my fellowship, we sought to identify the impact of subspecialty certification, both on orchiectomy rates and transfer rates. And we used the KID data sets from 2003 through 2016 and studied 3,400 boys who underwent or who had testicular torsion, looking at orchiectomy rates as a primary outcome and transfer rates as a secondary outcome. And we found, similar to the previous group that had studied earlier KID data and the other group that had studied FIS data, the factors associated with orchiectomy were Black race, Asian race, public insurance, and Midwest region. But we did not find that there was an association between orchiectomy and transfer. For looking at transfer rates as secondary outcome, we found that factors that were associated with transfer were not surprisingly micropolitan location or rural location. And then we found that those who had surgery after 2008 or the time of pediatric subspecialty certification were more likely to be transferred. In short, several national administrative databases have demonstrated the rates of orchiectomy are associated with race and insurance status. And single institutional studies that have come out more recently have suggested that parental education level and income may also play a role, but that still needs some further exploration. It's still unclear if transfers are increasing the risk of orchiectomy, but transfers are becoming more common since the pediatric subspecialty was introduced. And this, I think probably has the potential for some cost analysis, both on the healthcare system and for the patient. Excuse me. Newborn circumcisions are one of the most commonly performed procedures in this country, but sometimes patients may need an operative circumcision instead due to anatomic, health, or social issues that cause deferral of the office procedure. The group at Lurie Children's in Chicago has published multiple studies on access to newborn circumcision over the recent years. They've evaluated kid data for boys undergoing newborn circumcision to identify factors associated with getting circumcised and whether practice patterns changed following the American Academy of Pediatrics guidelines that indicated there was medical benefit to circumcision. They found that boys with public insurance were less likely to undergo newborn circumcision and that this held true year after year. They also found that circumcision over the years has differed by insurance status, race, and region. They demonstrated this graphically after stratifying by insurance status, showing that across the board, patients with public insurance had lower likelihood of having newborn circumcision, and differences by race appeared to somewhat attenuate over time. Decreases in newborn circumcision were sharpest in the South, likely due to insurance coverage changes over the time period that they studied. There are fewer differences in circumcision rates when evaluating by income quartile, only to show that while rates decreased among the privately insured, they still had higher likelihood to receive newborn circumcision than the publicly insured cohort across the board. This same group in Chicago surveyed 206 caregivers who presented to an outpatient clinic for circumcision in Chicago to determine the reasons why they had not had a circumcision performed during the birth admission. The majority of the patients were Black and on public insurance, and the insurance status at the time of birth was associated with reported ability to have a circumcision performed at birth. They also found that white patients were more likely eligible for the in-office circumcision than their non-white counterparts, suggesting that white patients were being referred or presenting at an earlier time to the outpatient clinic, and therefore could meet the parameters of having an in-office circumcision. A national survey to providers of newborn circumcision, which were split almost, 60-40, 40-60 urologists to pediatric hospitalists, was performed to understand hospital characteristics and institutional practices. And this showed that Western region hospitals and urban care centers were less likely to offer circumcision. But of the hospitals that offered circumcision, only 21% made the service available 24/7, meaning that some birth admissions, which take place at a time where circumcisions are not offered, such as over a weekend or a holiday, were happening across the board. When these provider respondents were asked why circumcision was not offered, they most often cited institutional or insurance limitations, and it was not for lack of trained providers. The group in Chicago then surveyed birthing hospitals in the Chicago area to gather institutional circumcision practices. All hospitals that they surveyed, which was around 44, reported that they offered circumcision either in the outpatient or inpatient setting or both. However, survey contacts at half of the hospitals could not verify if they accepted insurance or if they only offered circumcisions on a cash-only basis. Importantly, this survey was distributed in the same area as the caregiver survey they had previously administered, and 18% of caregivers from that original survey said they were not offered circumcision during their birth admission, representing a discrepancy between what caregivers received in their care and what hospitals believed they offered. This group most recently evaluated FIS data to identify patients who received operative circumcisions, knowing that this was likely an outcome of deferred newborn circumcisions. They compared the cohort of boys undergoing operative circumcisions to a control group of boys undergoing other elective outpatient surgeries. As expected, they observed just as they observed in their previous study of newborn circumcisions, which had declined over time, operative circumcisions have increased over time. They saw variations in percentages of operative circumcisions by race, seeing increases in operative circumcisions among Black patients. They saw variations in insurance status with slight increases in operative circumcisions in privately insured patients, but only slightly, just closing the gap only slightly with the high rate of operative circumcision still happening in the publicly insured. They also had variations by region, just as they found in their studies of trends of newborn circumcisions, with the highest number of operative circumcisions performed in the South, likely associated with changes over time in insurance coverage for newborn circumcisions, leading to higher rate of operative circumcisions. The financial effects of the shift from newborn circumcision to operative circumcision has been studied, and many states, in the past 20 years, dropped circumcision from insurance coverage. This was after the American Academy of Pediatrics came out in 1999 with a stance that did not recommend circumcision. Although, in 2012, that stance had changed, but in states like Louisiana, insurance stopped covering newborn circumcision under Medicaid, citing cost savings. However, Louisiana did not account in their cost-saving measures for the possibility of complications in the uncircumcised penis and the need for future operative circumcisions. So the authors of this study looked at the Department of Health circumcision data from before and after the 2005 coverage change that occurred in that state and created cost models for both newborn and operative circumcisions. They found that circumcisions decreased sharply around 2005 due to the lack of coverage for newborn circumcisions, but that operative circumcisions soon thereafter began to rise. When looking at the overall costs due to these trends, they saw annual expenditures sharply rise due to the increased per procedure costs of operative circumcisions, which now made up the bulk of circumcisions in the state. So when considering the effects of increased proportions of operative circumcisions, as have been demonstrated in several studies now, we think of increasing healthcare costs and the burden on the health system. However, there are risks at the patient level as well, including risks associated with anesthesia, with general anesthesia and the cardiopulmonary risks associated, and as well as the overall risk of adverse events in patients who have had a circumcision delayed past the year of life, which has been shown in previous data. So to recap, newborn circumcisions are decreasing, correlating with a rise in operative circumcisions in this country. Insurance status and race are associated with access to newborn circumcision, and region is also associated, but this may be in part due to a number of states that have no longer offered coverage for newborn circumcisions under Medicaid. The risk to the patient and the overall cost within our healthcare system is greater with operative circumcision, so we should be looking to increase newborn circumcision access more widely. Next, I will briefly highlight a couple of studies that expand our perspective and help us to consider areas where there may be hidden inequities in our care models. One of my former mentors, Kathleen Kieran at Seattle Children's, spent more than 75% of her time in Eastern Washington, about 3.5 hours away from Seattle and over a mountain range. So it sounds like 3.5 hours. Many times it was more like 5 to 7 hours away, or sometimes completely closed off because of snow. Most of her patients on the eastern side of the mountain range were from rural or agricultural parts of the state. And this led her to ask the question that, are the imaging tests that we commonly order as pediatric urologists available at the hospitals that are closest to where her patients live? So she set out to survey hospitals across the state and had an 84% response rate, asking which studies that each hospital performed. Nearly all hospitals offered abdominal x-rays and renal bladder ultrasounds, but very few rural hospitals, which are shown in the black columns here, offered VCUG, MAG3 renograms, or nuclear cystograms. This has implications for rural patient and families that they have to travel greater distance to obtain imaging studies that we order. And also, I think this demonstrates an opportunity for cost analysis for our patients who have to travel long distances or perhaps take off, whole days of work to obtain these imaging studies. Researchers in Colorado and San Diego looked at rates of patient portal use for their patients attending pediatric urology clinics in each city. They looked at whether patients or families were offered the opportunity to create a patient portal account and whether they went on to activate that account for use. The group found that patients who self-reported their race as other or who did not speak English were less likely to be offered portal access and less likely to activate the portal if offered. Interestingly, they found that one of the sites had significantly higher rates of portal enrollment and activation. That site offered Spanish language versions of their portal, as well as staff training for the staff that would be introducing the portal's functions to patients and families during their visits. The patient portal is increasingly becoming an important tool that we use for two-way communication with our patients. And I think that understanding some of the reasons why this portals are not being offered to families or why they're not accessing those portals is going to become critical. So when I think about opportunities to improve how we research disparities in care and how we eliminate these disparities in care, I first consider how we can improve on the front of education. For the undescended testis, delays in referrals lead to delays in timely surgery. We can improve the referral process through focusing on physical exam skills and knowledge of the AUA guidelines among providers who perform initial exams during well visits. We also can increase awareness for the guidelines on imaging, which can sometimes delay referral. We also must educate families on the importance of early evaluation and returning to us in urology clinic if exams at home or in the pediatrician's office change, and really examine how effective our current educational approach is at sending that message. The educational piece is highly important for testicular torsion because the time before the patient arrives at the hospital is the most critical time to the outcome, and it is the time that is least within our control. So educating on parental and child awareness of signs and symptoms that warrant immediate presentation, I think would be a great place to start and can be a great research project for future intervention. We can also examine how our healthcare systems create barriers to equitable care. As I showed earlier, the cost of an operative circumcision provides a clear justification to provide greater access for newborn circumcision and can be used to impact institutional and state policies in this arena. Implementing a coordinated system-wide approach to offer this service may be crucial in eliminating access disparities. Parental education of the options at the time of birth may also ensure that decisions during the birth admission and beyond are well informed. Within the Spina Bifida population, We need to understand how care that happens at home and outside the hospital or clinic is affected by insurance status, so that we can address the disparities we currently observe. And I will ask, is insurance status also a proxy for a complex constellation of sociodemographic variables we are not truly capturing within our registry data or clinical intake data information? Hopefully, more qualitative analysis of the patient experience can point us in the right direction and understand this a little bit better. For testicular torsion, there's already been some process improvement measures that have been studied to reduce the time that it takes to get a patient from the ER to the OR, but we should look to external transfers as the next frontier for quality improvement, with a mind to improve timely care for rural and geographically remote patients. To conclude, there is evidence of disparate care in multiple areas of pediatric urology, and we've just scratched the surface of understanding and characterizing them. Factors such as race, location, language, income level, and insurance status are associated with differences in access and in some cases, differences in outcomes. But it is unclear in many instances where these factors serve as a proxy for another marker or a complex set of factors that our current research methods have not yet allowed us to explore. While we need to refine our research, we also need to move away from the repetition of characterization and description and move into intervention. We know that the disparities exist, and now is the time to eliminate them. Here are my references. And as Dr. Farhat said, this is a quick plug for Urologists for Equity, which I helped to form last year. Its mission statement is to promote diversity, equity, and inclusion in urology through advocacy, sponsorship, scholarship, and engagement. I welcome anyone who's interested in learning more to go to the website below or follow us on Twitter. Thank you, everyone. I'm happy to take questions.
Thank you, Shannon. Shannon, for us in the division, we're 4 of us now. Do you have any suggestions on a short scale in short period of time that we can do to improve on the healthcare delivery, at least in the city or in the state?
Yeah, I mean, I think some of the low-hanging fruit would be, looking at an institutional level at, our patient population and time for referrals. If that hasn't already been done, there's not actually, beyond what I've presented in this presentation, there's not like a significant body of literature. I presented the highlights, but, below the surface, there's not that much more. So I think, the best place to start is at an institutional understanding of where our deficiencies are, and then employing quick interventions to, decrease referral times and understand where we need to educate providers that are referring to us.
Thank you.
Shannon, this is Vinaya. That was such a wonderful presentation. I wanted to ask you, how can we bridge the kind of patient education / informed consent gap for families that may not have good health literacy or access to self-education resources, things like that, at least for, urologic conditions?
Yeah, I think, some people are starting to look at, multiple modes of education. I think for most of us surgeons, the education piece is in our clinic visit, or, for emergency things during the very brief time we meet them beforehand. But I think that there's opportunities for using things like videos, for having patients record information that we give, for having, print information that is studied and then validated and then sent out for patients. I think those are good ways to start. And then I think there's, kind of on a larger scale or maybe more ambitious scale, looking at, for some information, how to distribute it outside of the healthcare model. So for instance, distributing information to parents through schools about, things that they should be watching out for in their children. I think at the very least, we could potentially partner with pediatric providers who see patients to help, understand how we can provide, anticipatory guidance for parents for things to watch out for. But I think that, at the most basic level, we need to improve how we educate our patients. And I think that's through kind of multiple modes of teaching.
Shannon, Dan Williams here. Terrific talk, and so great to have you on board to continue to explore these topics. My question is, I heard one big theme, which is my impression is access to care, and you nicely described that with the different models that people had looked at as far as the different insurances and such. How do we sort of unbundle access to care, which is probably or maybe an easier one, versus what may also be a more difficult and more challenging one, with biases, either implicit or conscious, subconscious biases with these items. And I guess I frame that in the sense that this last year and a half, 2 years that we're still living through with COVID, we've seen the sort of the acceleration of telehealth really help to expand access to care. But how do we sort of unbundle those different things in these studies that when we're looking at equity?
Yeah, I think that's a great question, and I feel like it is hard to unbundle those, and I think part of the problem lies with, I think, the historic, this is something that we touched on at our journal club, the historic views of how we do this research are, really deeply seated into our administrative data. So the idea of having these racial categories, which, may belie several different components that kind of play into why at the end result, you see that there are, worse outcomes for Black or Hispanic patients. And we don't have the data to look at those kind of underlying factors that lead to that very clunky answer at the end of the study, because it's just not in the data. I think that some of the and that itself is at odds with the idea that some of these data that I presented showed that not only was there inequity based on insurance status, there was inequity based on race. And so, yes, a larger percentage of those patients who are Black and Hispanic may have, public insurance and be at risk from that standpoint. But there may be an element of, unfortunately, discrimination that plays into that as well. But we have no way to quantify it because there's also potentially other things at play that, really detract from using that as a factor that, just because it really does encompass so many things. I think, one of the things that you asked about was, like, how do we provide access to care in a more equitable fashion? And I think, really what people are not looking at are, who's accessing these modalities that we now say are really, really improving our access. So, for telemedicine, are we providing telemedicine visits at the same rates to patients who speak other languages? Does this truly improve access for patients whose families are, like working poor, who might need to take off a significant chunk of work regardless of what you offer them because, they can't do the visit from their work? So I think there's just many components that have been left unstudied that still need to be explored. But I think starting with what we offer as an institution, getting away from kind of showing evidence of disparity from a national administrative level helps us to understand how we can provide interventions to actually improve the access and hopefully reduce bias that we can at least address. We can't address the implicit bias as easily. That's hard work.
Other questions for Dr. Cannon?
Actually, I typed it in, but
Oh, sorry.
and on it. Yeah, really a great talk. Boy, what a complex subject. You know, you think obviously sort of better access, more of a universal healthcare approach would help, but clearly there are other factors that play into this. You know, I think your comments about accessing you know, healthcare through schools is a great idea, and that's where you have an opportunity to access the kids directly. Are there examples of systems that have had this kind of issue that have changed their healthcare system in a positive way to really impact these problems?
I unfortunately don't have an example of one. I do know, you know, there are some models, as you were talking about, of offering healthcare through schools. These are, you know, in larger cities and sometimes like magnet or charter school settings. But I think as far as healthcare systems, you know, aside from kind of the HMO models like Kaiser Permanente, which is still at the end of the day, a privately insured group of people. You don't see kind of these, you know, big concerted efforts to provide system-wide access. And I think, you know, as physicians, that could be a point of advocacy for us. But I think it takes a lot. It'll take a lot of effort to move the needle there.
Yeah, and I guess what I was getting at is, did the Affordable Care Act move the needle at all?
Yeah, I mean, I don't, the data that I'm seeing has not borne that out, but, you know, we're still, you know, about what, like 10 years less away from that change. And so I think that's still yet to be seen.
Yeah, thanks.
Thank you.